Welcome you all to the second heart failure group virtual seminar. Really tonight we have fantastic speakers. I'm really looking forward to this. You will all learn and I will learn. I look forward to your joining in interaction, discussion to our organizer. So tonight we have very interesting topics, the management of hyperkalemia, heart failure, and iron deficiency. I'll introduce my first speaker, my dear friend, Dr. Hussein Hishmet. If anybody lives in cardiology doesn't know him, then he doesn't follow cardiology. He's very well known. He's really a fantastic speaker. I always enjoy his talks. He's a professor of cardiology at Cairo University. He's a associate editor of the Egyptian Heart Journal. He's a top-notch interventional cardiologist, but to me, he's actually top-notch speaker. He has actually done more than 30 international publications. He has his own YouTube and education. Actually, I log into it sometimes, and every time I learn a lot. Tonight, he will kindly talk to us about the RASI enablement therapy in patients with hyperkalemia. Dr. Hussein, floor is yours.
Thank you so much, Dr. Mohammed, for the very kind introduction. It's very kind of you, and I would like to thank all the audience for taking part of their precious time and coming to listen to us. And in the coming 20 minutes, I'll be talking about how to enable the guideline-directed medical therapy, especially in the presence of hyperkalemia. I have no disclosures, and a big part of what we've been doing in the last 30 years in heart failure with reduced ejection fraction is piling medications over and over. So we started by ACE inhibitors, then we had beta blockers, then we had MRAs, then we had sacubitril, valsartan, then we're having vericiguat, and they seem to work really outstanding. So over the last 30 years, thanks to these 4 medications, we were able to reduce the all-cause mortality of heart failure by more than 60%. And the same applies to cardiovascular mortality, heart failure mortality, hospitalizations, and all aspects of heart failure. But unfortunately, what we see in clinical trials is not translated in a one-to-one manner to our everyday practice. Because there are many barriers in real life that are not in the randomized controlled trials. And I will not be speaking about the cost, about the polypharmacy, but I will be speaking about the biggest barriers that we see in practice, and they are limiting us from using guideline-directed medical therapy and up-titrating. We have the 3 biggest barriers are hypotension, the change in the renal chemistry, and the elevation of the serum potassium. And today we'll be focusing on hyperkalemia. We'll be talking about potassium and hyperkalemia, the relation between guideline-directed medical therapy, heart failure, and hyperkalemia, how traditionally we manage hyperkalemia, and how could we better manage hyperkalemia with the new tools that we have currently in hand. So looking at serum potassium, unlike other biological variables that are regulated across a wide range of values, like the blood sugar, like the serum creatinine, like the blood pressure, like the heart rate, serum potassium is different because it's really regulated across a very narrow range of what we think to be the normal. So in early days, we used to think that the normal serum potassium would be between 3.5 and 5.5. But when we look into large databases of close to 900,000 patients, the real normal value seems very tight, between 4 and 5. And once we go below 4, we see a rise in mortality. And once we go above 5, we start to see a rise in mortality. And of course, the rise becomes steeper whenever we have chronic kidney disease, diabetes, heart failure, and it becomes steeper more and more if we have a combination of these risk factors. and it applies to mortality, to all-cause mortality, and to major adverse cardiac events. It seems like we're walking on a tight rope of serum potassium, and we can easily fall into the hypokalemic side and easily fall into the hyperkalemic side. And falling on the hyperkalemic side seems to be a drastic event. We've all seen it across the years of practice, throughout the years of practice. Hyperkalemia, whenever it crosses the range of 6 and 7, then it becomes a lethal condition. And you can remember those patients who came with presumed complete heart block and you were planning to put a pacemaker, then you find that their serum potassium is 8. Or those patients with a cardiac arrest, you start resuscitating and you see that rhythm and you give them calcium gluconate and then they start to recover. These events of drastic elevation of serum potassium leave a mark in our minds and in our hearts, like scars in the minds of the practicing physician. And we don't want to see them again because these are fatal or near fatal events. And then, because we don't want to reach the 7 or the 8, and because we saw that the potassium level is regulated across a very narrow range, so the guidelines reduced the definition of hyperkalemia from 5.5 and they became 5. And of course, once we cross 5, then we get worsening. And as we go higher and higher, we see that the risk rises in a graded manner and it applies to all-cause mortality, to worsening renal functions, all-cause hospitalization. The higher the serum potassium, the worse the outcome. Another peculiar feature to hyperkalemia is the tendency to recurrence. Unfortunately, hyperkalemia is rarely a single event in the life of the patient. They tend to recur, and not only they recur, but they recur at an increasing or a shortening duration. So if the second event would occur after 6 months, the third event would be even closer, 5 months, and the fourth event would be even closer, 4 months. So that it's not just one event and it can be fatal, it tends to recur. We know that from a large cohort of Danish patients. And hyperkalemia is a common concern for internists, for nephrologists, but it's of a particular concern for us, the cardiologists, because you've seen those therapies that lower the mortality and improve the outcome in heart failure. 3 of them are known to cause hyperkalemia. ACE inhibitors, ARBs, ARNI, MRAs, whether they are the steroidal, spironolactone, or the new non-steroidal MRAs for chronic kidney disease. And we sometimes forget that also beta blockers are associated with more hyperkalemia. So if we combine the 3 of them, as we like to do, then the chances of developing hyperkalemia are real. If we take the cutoff of 5, then roughly 1 out of every 4 heart failure patients would develop hyperkalemia in their lifetime. If we take the cutoff as higher, 5.5, then roughly 10%, which is still a large proportion, 1 out of every 10 HFrEF patients from the Swedish registry will develop hyperkalemia. And of course, as we have a constellation of risk factors, then the chances of hyperkalemia become more and more. Age, diabetes, heart failure, chronic kidney disease, if we combine them all, then roughly 1/2 of the patients would have hyperkalemia. And during the tragic event, of course, we know the management, immediate stabilization of the membrane by giving calcium gluconate to stabilize the membrane. Then we need to shift potassium from the plasma into the cell. We use insulin, dextrose, inhaled beta-2 agonists, and sodium bicarbonate. This is within the first hour or 2. Then over the following few days, we used to count on increasing loop diuretic, giving the traditional potassium chelating agents, and in some cases where all our measures fail, we may resort to dialysis as the life-saving measure. So these are all effective in the acute phase. But looking at the long-term options and keeping that we have in the back of our minds the traumatic event of severe hyperkalemia, what long-term options do we have? The easiest option, because it's a negative action, is to just stop the offending medication, because we don't want the patients to accuse us. We need to go home and sleep well, because you don't want to be awakened again. So you try to get rid of whatever we assume to be the offending agent. It could be a RAS blocker, it could be an MRA. And looking at the guidelines, the thresholds are slightly different. Of course, it's very strict for MRA. Aldosterone antagonists should not be started if potassium is more than 5. And this is consistent across the NICE guidelines, the Heart Failure Society of America, or the ACC guidelines. For RAS blockers, it's way more gray. There's a general agreement. Of course, we stop them if we cross 6. But if we're between 5.5 and 6, then you can either stop or reduce the dose. It's left to the discretion of the treating physician. So what do we do in real life? Of course, once we see the potassium crossing 5 or 5.5, then half of us would discontinue the MRA. The other half, the brave half, continue, but they will reduce the dose. And concomitantly, we would reduce ACE inhibitors, ARBs, new diuretics, new potassium prescribed potassium chelating agents, keeping in mind that once we discontinue, we usually do not reintroduce these agents at least for 1 year, until the looming memory of the hyperkalemic event fades away. So we do that and we feel comfortable. But in reality, when we do that, we're replacing one threat or one disease with another disease. We minimize the risk of hyperkalemia, but we get instead worsening heart failure outcomes. It's not just heart failure, it's worsening chronic kidney disease, worsening heart failure, worsening diabetes mellitus. And it applies to all the agents of heart failure. Taking the ARNI, these are data from the paradigm, those patients who had to reduce the dose of the ARNI because they could not tolerate it because of hyperkalemia. And you see here what happens. The two curves are identical, but the event rate is magnified once we reduce the dose of ARNI. Instead of having an event rate at the 25%, here we have an event rate at the 40%. The same applies to MRA. When we discontinue MRA, we get a 30% increase in mortality. When we stop MRA, beta blockers, and ARNI in patients with dilated cardiomyopathy, then roughly 50% of them would relapse their condition within 6 months of withdrawal. So we tend to have a false sense of security that we remove the offending agent, but we are flaring heart failure instead. So what happens in real life, in addition to discontinuation? We tell the patients, go for a low potassium diet, but keep in mind that we also tell heart failure patients that you need to go on a low sodium diet. And so the potassium-rich diet is the diet that we love. It's the Mediterranean diet. It's the DASH diet. So we tell the patient not to take sodium, not to take potassium. So they are left with very few options. Increasing the dose of the loop diuretics means an impact on the kidney functions, dehydration. Bicarbonates and the traditional potassium chelating agents are not practical because of their side effects and tolerability. If we look at just the first month, only 30% of patients would be taking the calcium resonium. And there's an FDA warning from the prolonged use of these potassium chelating agents because there is a serious risk of necrosis of the colon. So we don't have really practical long-term solutions for hyperkalemia, and we lose when we stop the beneficial therapies. And more than 10 years ago, we started to see agents that are more tolerable, that are more effective, and can be sustained sustainably used for more than 1 year. So we have currently two agents. We have patiromer and we have sodium zirconium. Patiromer is a polymer. It's an oral agent. It's not absorbed, so it doesn't have a systemic effect, and it's indicated for hyperkalemia. It starts the effect 4 hours after the administration, and it has some drug-drug interaction, so we need to keep the medications 3 hours on each side of the dose to avoid the interference with the absorption of medications. It's given in a once daily dose. The most common dose is 8.4 grams, and we can increase and titrate every week if we don't see the desired effect, up to the maximum dose of 3 sachets, which is 25 grams per day, can be taken with food or without food, can be taken with apple juice or cranberry juice. And it has a good deal of evidence, starting, as you see, from more than 12 years ago in the dose-finding trial, the Pearl heart failure, which recruited patients with decompensated heart failure. It was more of a dose-finding study and a side effect finding study. They looked at heart failure patients who had hyperkalemia or patients with chronic kidney disease who had hyperkalemia in the previous 6 months that resulted in discontinuation of therapy. They randomized them to patiromer or placebo, and at the end of the first month, they found that 91% of patients who had hyperkalemia and given patiromer were able to reach the maximum dose of spironolactone compared to 74% in placebo. And we get to see here the magnitude or the potency of patiromer. It's usually able to reduce the serum potassium between 0.5 millimole and 1 millimole. And remembering that the potassium is regulated across 3.5 to 4.5, so probably you don't need more than that to bring down the potassium into the normal range. And there is a bigger stage 3 trial which was published last year. It's the Diamond heart failure study. And this is a really big study. It's more than 1,000 patients. All had heart failure with reduced ejection fraction. After a run-in period to test the efficacy and the tolerability of patiromer, they were randomized into placebo or patiromer. Keeping in mind that all of these patients had a serum potassium more than 5 or a history of hyperkalemia that required discontinuation of RAS therapy. They were all heart failure with reduced ejection fraction, but they didn't have decompensated heart failure, hypotension, or an eGFR less than 30. These patients were excluded. But in the run-in phase, they made sure that the patients were all given a 50 milligram dose of spironolactone and more than 50% of the ARNI or the ACE inhibitor dose. Then they were randomized to patiromer or to placebo and continued for 1 year. And this trial was very strict. They monitored the serum potassium almost on monthly basis. And in the patiromer arm or in the placebo arm, they looked at the serum potassium, and if the serum potassium was high, then they could up-titrate the dose of the patiromer, or if the serum potassium crossed the limit of 5.5, they would discontinue the RAS blocker. And what happened at the end of 12 months? You see again the same change in serum potassium with patiromer, which reflected on being more likely to have the biggest dose of MRA and less likely to reduce the dose of MRA and less likely to reduce the dose of ACE inhibitor. And if we compare the group of patiromer versus placebo, hyperkalemic events were reduced by 1/3 with patiromer. Continuing MRA to the target dose was 40% or 38% more with patiromer. Hyperkalemic events more than 5.5 were again 30% less with patiromer. And the study had to be modified because of COVID-19 that affected many trials, as we'll see. So they were not able to look at heart failure mortality or hospitalization as we wish to see. But looking at the win ratio, which is a statistical tool to look into smaller trial sizes, looking at mortality or heart failure hospitalization or hyperkalemic events, you see that there was a 25% in favor of patiromer. The study helped us to identify the side effects, which is a concern for any physician, and comparing it to placebo, probably the GI side effects were the only ones that were slightly more common. Hypomagnesemia was not a big concern. Hypokalemia could be of a concern, but the adverse events were similar between patiromer and placebo. And we have another agent, which is sodium zirconium. It differs from patiromer that it's not a polymer, it's inorganic. It doesn't work through the colon, it works throughout the entire GIT. And this may give it an advantage that compared to patiromer, which takes 4 to 7 hours to start acting, with sodium zirconium, you see an effect within the first hour. So it may be fitting more into the acute phases where you need to achieve a faster reduction of the serum potassium. Hypokalemia remains also some concern, and there's also a concern of edema because this is basically sodium. And the standard dose, which is 5 grams, usually does not result in edema, but the dose of 15 grams, which is luckily not available in the UAE, can result in some edematous events and volume overloads. But in most of the cases, the 5 grams will not result in edema. Sodium zirconium usually, unlike patiromer, does not have the interactions with all of the medications. It has some interactions with a few medications that we rarely use. You need 2 hours before and 2 hours after. Sodium zirconium was tested in a group of trials that included heart failure patients, and you see again the same effect, which is roughly 1 millimole per liter reduction in serum potassium. The trial of zirconium, which was equivalent to the diamond trial, again was affected by COVID, so it had to be stopped. But the meta-analysis, if we combine the data from sodium zirconium and patiromer, we see a significant benefit in terms of reducing the hyperkalemic events. And now these are the two competing agents. I don't think that it's the focus of this talk to compare both agents, but it seems that for patiromer, we tend to have slightly more GI side effects and slightly more hypokalemia and hypomagnesemia, whereas with sodium zirconium, we tend to have more sodium load and edema. You can feel free to use whichever agents. I had more experience with patiromer and recently with sodium zirconium, and they both seem to work fine. And this is reflected in the guidelines, in the ESC guidelines and in the ACC guidelines. The ESC is more liberal and is more welcoming. These agents may allow the uptitration of RAS inhibitors in the MRA. In the American guidelines, they are given class 2B because the guidelines were published before the release of the Diamond trial. So we expect that these recommendations would become more welcoming in the future. So based on the availability of these two agents, instead of the traditional approach to hyperkalemia of stopping RAS inhibitors, stopping MRA, forgetting them, increasing diuretics, old potassium chelating agents, we need to be starting with patiromer or sodium zirconium, closely monitoring the serum potassium. And if these modern binders would fail, then we could down titrate or stop the RAS inhibitors. This is my message today. Thank you so much.
Thanks very much, my dear friend Hussein. I forgot to remind the audience that they need to write the question in the chat box. But if I don't mind, Hussein, I'll ask you a couple of questions. First, regarding actually the definition of hyperkalemia, because hyperkalemia is really not always. Because people think hyperkalemia patient has to be hyperkalemic all the time. when do you decide to start this agent? We do it sometimes, repeat it, it comes back to normal, but you reduce the agent, the standard tone, and then reintroduce it, it becomes fine. I mean, at what stage you say, now we have to interfere with these agents, or we have to add these agents?
Yes, looking at the trials, they looked at a serum potassium more than 5, because once you cross 5, then I think that most of us would not give any MRA. So if you need to enable the MRA, then I would consider 5. If you need to enable the ACE inhibitor or the ARNI, then you can wait for probably 5.5.
Yeah. And I think the definition you said, it's a recurrent thing.
Yes.
You see it, I look at the patient chart, and he had it before, and if really had it with me, then that's it. It's a decision.
Yes. If he crossed 5 and you, or 5.5, and you want to start an ACE inhibitor and feel a bit safer, then I would go for these agents.
Diet doesn't work. A question regarding, you mentioned the hypomagnesemia with bacteremia. Do you check for it? I know it's not in the diamond, but it's been previously reported. Do you check for it? Do you have to monitor magnesium?
I usually monitor the magnesium hand in hand with the potassium.
Okay.
Because we're worried about hyperkalemia, but we're also worried about hypokalemia. And these agents can produce hypokalemia. So it's part of the regular monitoring. And we can discuss what is the frequency of the monitoring. Is it every 1 month? Is it every 2 months? I think it depends on how frequent we bring the heart failure patients for follow-up. If they're coming for every month or every 2 months, then I would do a renal profile and then electrolytes every month or 2 months.
Yeah, regarding the Lotelma, you mentioned it works within 1 hour. The drug company advocating use it as an emergency tool, and I know it has been done in nice. Is this something you go with, recommend, or is this something somebody comes with hyperkalemia, do you start hand in hand, take this study with them on?
Well, I would give the treatment immediately, but I will not expect that they will cancel the role of calcium gluconate or sodium bicarbonate or glucose insulin. It's nice to have them starting to work after 1 hour, but we've seen the magnitude of reduction. They will not bring the serum potassium from 7 to 4 in 1 hour. This is very unlikely. So you still need to count on the strong glucose insulin and sodium bicarbonate, etc.
The other question for me is regarding use in end-stage renal failure dialysis.
Yes.
No, there is something.
Yes, if we look at the Diamond trial, they excluded patients with eGFR less than 30, but as the trial went on, some patients dropped their eGFR below 30 and it was used. So that's looking at the randomized trial. But in fact, we have real-world evidence more than we have randomized control trials on the dialysis patients. And in fact, we have data for both agents. We have data for bacteremia and we have data for sodium zirconium in dialysis, and they seem to work as well.
Question from the audience. First, say how to treat a patient with hyperkalemia and an arrhythmic disorder requiring prolongation of the effective refractory period.
Okay, these would be managed emergently with calcium gluconate, intravenous calcium gluconate, and then I would recheck the serum potassium in less than an hour and make sure it came down. If it doesn't come down, then I would go for glucose insulin, inhaled beta-2 agonist, sodium bicarbonates, and sometimes dialysis.
I think the second question you already answered about how frequently you check the potassium and the magnesium. You already answered that. I think that's it. I think we'll probably move on to the next talk. Thanks very much, Dr. Hussain. Really appreciate it. Right. It gives me great pleasure to introduce my second speaker, Dr. Hadi Skouri, really, again, does not need any introduction whatsoever. He's a big hero in heart failure in UAE, and he's a associate professor of clinical medicine cardiology. He's a consultant in Sheikh Shakhbout Medical City in cardiology, advanced heart failure, transplantation, and cardio-oncology. He's a board member of the Heart Failure Association of the European Society of Cardiology, and he's the chair of the Heart Failure Group of the Lebanese Society. He's a great speaker, and I've listened to him so many times. I always learn from him, and I really, really appreciate him accepting the invitation. And tonight, he will talk to us about something really, really sort of important and evolving, and there is new data even just from a few weeks ago. And I'm sure he will give us all the necessary information. So that's iron deficiency in heart failure. And my friend, Dr. Skoury, the floor is yours.
Hi, good evening. Thank you, Muhammad, for this kind introduction. And already you have introduced the topic, so I will talk about the management of iron deficiency in heart failure, especially that the update of the recent heart failure guidelines dedicated one part for this reason. So basically, I have nothing to disclose, and I would like to start with a presentation, then define iron deficiency in heart failure and the impact of iron deficiency on heart failure outcome, and how are we going to replace iron in patients with a chronic and acute heart failure, what the guidelines say, and what are the gaps that are still there, and some take-home messages. We know that comorbidities in heart failure are a lot, and in the 2016 guidelines, they mentioned around 17 comorbidities. One of them is anemia and iron deficiency. The importance of comorbidities is because they interfere with the diagnostic process and sometimes, or can they aggravate the heart failure symptoms and impair the quality of life of these patients, contribute to the burden of hospitalization and mortality. And as we can see, iron deficiency is one of them. They can affect the treatment for heart failure, and Dr. Hussein already mentioned about hyperkalemia and chronic kidney disease. Also, we know that most of the studies and most of the landmark trials, they excluded some of these comorbidities. Always there is drug-drug interaction with the treatment of comorbidities as well as treating heart failure patients. So this is why management of comorbidities is a key component of the holistic care of patients with heart failure too. So when we talk about the management of heart failure, we don't only aim at improving survival and reducing hospitalization, but also improving quality of life is as much important. And we know up till now, the majority of treated patients remain symptomatic even if they are on quadruple therapy of heart failure management. You all see in your clinics and encounter such cases. This is a 62-year-old gentleman with ischemic cardiomyopathy and a low EF of 20 to 24%, heart failure with reduced ejection fraction. He's actually on the quadruple therapy of ARNI, beta blocker, MRA maximum doses. 3 months ago, he was started on SGLT2 inhibitor, and 1 year prior to that, he was implanted a CRTD with no ICD shocks. He was admitted with acute decompensated heart failure. Knowing that he was seen 1 month ago in the clinic, he was NIHA class 2 to 3. He was complaining of fatigue and tiredness. There was no infection. He was not hypovolemic. He is not COPD. He was screened recently for malignancy, and he was screened for sleep apnea, and he's not in sleep apnea. So always when we think of patients with optimal medical therapy and the heart failure with reduced ejection fraction, and he's still symptomatic, we have to think, in addition to sleep apnea, we have to think of anemia, iron deficiency, as well as depression as most common causes that may improve, impact the symptoms of these patients. So in our case, I screened him for iron deficiency. His hemoglobin 13.5, which is within normal, but his ferritin 56, transferrin saturation 15%, and his iron level is 12.2 micromole per liter. So the question is the patient iron deficient? Is iron therapy indicated in this patient? Does oral iron help, or IV iron is needed? Can IV iron be administered before discharge if patient is admitted? Can IV iron be administered for long-term duration? And which IV iron formula can be administered? So all these questions may come into our mind. First, we want to just highlight that anemia is prevalent in heart failure patients, and there are multiple mechanisms for the development of anemia. It's not only fluid overload and hemodilution, but decreased intake of food, anorexia, malabsorption, bleeding, especially patients they are on anti-dual antiplatelet or antiplatelet for ischemic heart disease as the most common cause of heart failure, or oral anticoagulation for atrial fibrillation. In addition, heart failure is an inflammatory state that may increase inflammation that will produce hepcidin level in the liver that will reduce erythropoiesis and may affect the erythropoiesis in the bone marrow, causing anemia at the end stage. So there are multiple causes of anemia, and it's prevalent, whether in registers and in clinical trials. Anemia is highly prevalent, and it also depends on the definition of anemia from different trials. But from the CHARM program, where it has been shown that anemia impact mortality and hospitalization. Patients with anemia, whether with heart failure and reduced or heart failure with preserved ejection fraction, they have a higher incidence of death and hospital admission. And from the ELITE-2 trial, also with heart failure patients, the lower the level of hemoglobin, the higher or the lower the survival rate of these patients. And these were the studies that made this trial, the RED-HF trial, giving darbepoetin alpha versus placebo in heart failure with reduced ejection fraction with anemia, that was published in 2013. And actually, even though giving them darbepoetin alpha improved their hemoglobin level, but it did not affect the primary endpoint, death, hospitalization, or cardiovascular death from cardiovascular causes. Not only that, it was neutral, but also increased the risk of cerebrovascular accidents, especially ischemic, embolic and thrombotic events, and as well as mixed arterial and venous embolization. So even it's neutral, but also it may be harmful. And this is why it was indicated as a class 3 indication for heart failure patients, to give darbepoetin alpha in these patients to improve anemia and reduce anemia and improve hemoglobin level. But we know that the most common cause of anemia is still iron deficiency in green, whether in the 1990s or in 2013 in this study. And if we see the most common cause of anemia across the age groups, even elderly patients above the age of 80, still iron deficiency is the most common cause of anemia. And we also know that iron has a significant role in oxygen transport, oxygen storage, cardiac and skeletal muscle metabolism, as well as synthesis and degradation of proteins, lipids, and ribonucleic acids. So it has an important role in our body. And iron deficiency has been recognized not only in heart failure patients with reduced EF, but with preserved EF, in coronary artery disease, in cerebrovascular disease, in aortic stenosis, atrial fibrillation, and pulmonary hypertension. But only heart failure with an EF less than 50%. There are a lot of studies that have shown the impact on outcome, as well as treatment, the impact with giving them IV ferric carboxymaltose, and they were included in the guidelines. There are different definitions of iron deficiency across different causes of iron deficiency, whether in chronic heart failure, in chronic kidney disease, inflammatory bowel disease, or active inflammatory bowel disease. But in heart failure, the most common definition of iron that has been used all over the trials was a ferritin level of less than 100 or a ferritin between 100 and 300 with a transferrin saturation less than 20%. How do we calculate transferrin saturation? It is iron over total iron binding capacity. And according to this definition, iron deficiency is prevalent up to 50% in chronic heart failure patient and up to 70 to 80% in acute decompensated heart failure patient. It's not only that, but even In non-anemic patients, around 45% of them, they have iron deficiency. And iron deficiency has been related to the New York Heart Association class. The higher the NIHA class, the higher the iron deficiency in these patients. And iron deficiency is not only prevalent in reduced EF, but mildly reduced as well as preserved ejection fraction. Even it's higher in preserved ejection fraction. And what is the impact of iron deficiency on exercise capacity? Actually, it reduces exercise capacity by decreasing peak VO2. Even patients who are non-anemic and have iron deficiency, they have decrease in peak VO2. And this has been across the ejection fraction, whether reduced, mildly reduced, or preserved ejection fraction. It's not only on exercise capacity, but also on survival. Patients with iron deficiency have a lower survival rate, and patients even without anemia and only iron deficiency, they have a low survival rate. But combining anemia and iron deficiency, they have the lowest survival rate in this population. And if we go at the molecular level and the cell level, when we have iron deficiency in the cardiomyocytes, we have decreased contractility. And replenishing iron in these cardiomyocytes, actually in blue here, it replenish or it resume myocyte contractility as the normal contractile myocyte. And this is a study first in a human using cardiac phosphorus 31 magnetic resonance spectroscopy, measuring phosphocreatinine and ATP ratio, which is a marker of cellular energetic status. And actually, patients with iron deficiency have a low peak creatinine over ATP ratio, meaning that they have less energy status in this in the myocytes. And if we compare here, cardiac myocytes with normal iron status versus cardiac myocytes with deficient iron status, we can see that deficient iron deficiency myocytes, cardiomyocytes have decreased in contractility in these patients. And not only the cardiac myocytes, but also the skeletal myocytes in the human being, as well as the respiratory myocytes, the chest muscles as well that are involved in the respiration process. They are involved also when they have iron deficiency. We have decreased energy in them and decreased contractility. Thus will affect respiratory status, and they may be a cause of the symptoms that are related to heart failure patients. So iron deficiency in heart failure patient is not only related to decrease of PO intake of iron, but also of other elements. One of them is the inflammatory. Whenever we have increased inflammation, we have increased hepcidin from the liver that will block ferroporotin, that will reduce absorption of ferrous to the blood vessels, and this will decrease iron absorption from the intestine to the blood vessels, in addition to others like PPIs that will reduce iron, the acidity in the stomach, and thus will reduce that formation of ferric to ferrous sulfate, as well as edema that will reduce also absorption, bowel edema that will reduce absorption of iron to the blood. And there was a lot of publications over the last 10 to 12 years studying iron deficiency and treating them with IV for iron to treat them and see the effect on the outcome. First was the FAIR-HF trial, which randomized around 450 patients in a double-blind placebo using the same definition of iron, ferritin less than 100 or between 100 and 300 with a T-sat less than 20%. And the primary outcome was just study at 24 weeks, the NIHA class, and if the symptoms of the patient, and secondary endpoints were 6-minute walk test and the quality of life. Actually, there was improvement in the primary endpoint regardless of the presence of anemia, as well as consistently improvement in NIHA class, patient global assessment, as well as KCCQ overall score and 6-minute walk test. Then came the CONFIRM-HF trial, which was published in 2015 with the same thing, EF less than 45%, same definition of iron, and the primary endpoint was change in 6-minute walk test from baseline to 24 weeks. And in this study, actually, patients with ferric carboxymaltose has significant improvement with a p-value of 0.02 compared to placebo at 24 weeks in improving the 6-minute in these patients. Other secondary endpoints were NIHA class and KCCQ, all were favoring intravenous ferric carboxymaltose group. But not only that, but first hospitalization due to worsening heart failure as a secondary endpoint, and this was the first study showing significant reduction in hospitalization due to worsening heart failure in the ferric carboxymaltose group. And this was the study that included heart failure in the 2016 guidelines with recommending IV ferric carboxymaltose to reduce symptoms and as a class 2A to reduce hospitalization. But always to come the question, oral iron, is it efficient? And this is one of the studies is the iron out study giving oral iron polysaccharide 150 milligram BID versus placebo, and they studied the follow-up visits at 8 weeks and 16 weeks, the 6-minute walk test, KCCQ score, as well as cardiopulmonary exercise test. Actually, there was no difference between the two groups, and as we see here, that the ferritin level and TSAT level actually didn't improve with oral iron, and this is why oral iron is not a choice in heart failure, especially with the mechanism I already alluded before, edema, decrease oral absorption. Then came the AFFIRM-AH trial in IV in acute heart failure trial, where the primary endpoint was composite of total heart failure hospitalization and cardiovascular death up to 52 weeks. So they randomized ferric carboxymaltose versus placebo, and after the screening process and the inclusion criteria were according to iron deficiency, according to the previous guidelines, the same, with an EF less than 50%, and they confirmed acute heart failure from signs, symptoms, and NT-proBNP level. And they introduced IV iron depending on the hemoglobin level as well as the weight of the patient at week 0, week 6, and week 12 and 24, depending if they are still persistently iron deficient. And they randomized 558 patients in the ferric carboxymaltose arm and around 550 in the placebo arm. This is a trial in the COVID era, so there was intention to treat analysis as well as pre-COVID-19 sensitivity analysis. Baseline characteristics of these patients, they actually are a sick patient group because they have a very high NT-proBNP. They have around 50% of the patients, they have a low GFR in this population. And the primary endpoint actually did not meet the statistical significance with a p-value of 0.059 for total heart failure hospitalization and cardiovascular death. Only total heart failure hospitalization was significantly reduced. Cardiovascular death was not reduced, as well as other secondary endpoints. But if we come to the COVID-19 sensitivity analysis, then all the primary and secondary endpoints were statistically significant except for cardiovascular death. So it's mainly driven by heart failure hospitalization. And there's always a question about phosphate when giving IV iron. And actually, there was no reduction. There was mild reduction at the beginning of 6 weeks, then there was no reduction up for further. So then a sub-analysis of this trial, AFFIRM-AH trial, has shown that there is significant improvement starting week 4 up to week 24 of improvement of the quality of life measured by KCCQ 12 overall summary score. And this was the reason of including IV ferric carboxymaltose in the 2021 guidelines, not only in the chronic cases, but also before discharging the patient from the hospital, giving them IV ferric carboxymaltose. Then at the end of 2022 came the Ironman trial, which is a bit different from the AFFIRM-AH trial because it included acute and the chronic heart failure, acute in around 20% and the chronic in around 80%. But the duration of the trial was larger, 2.7 years compared to only. And the definition of iron deficiency is less than 100 or TSAT less than 20%, EF less than 45%. And they divided hemoglobin level depending on if they are women between 10, 13 and men 14. And they gave IV iron every 4 months, while in the AFFIRM trial at week 12 and week 24. And the primary composite endpoint was hospitalization, heart failure hospitalization, but with cardiovascular death, and actually the same number of patients. This is the randomization of the patients, and also did not meet the primary endpoint or the secondary endpoint. And COVID-19 analysis, when it was performed, it met the primary endpoint with 0.047. So always, these are two trials that they were conducted during the COVID era, and COVID-19 analysis have significantly reduced the primary endpoint. There were several meta-analyses after these trials that showed that there is significant improvement in hospitalization by giving IV ferric carboxyl dose, but there was nothing related to death in both in IV ferric carboxyl dose or in the other trial, the Ironman, where they used ferric derisomal dose. And this was the recommendation of the 2023 guidelines. Intravenous iron supplementation is recommended in symptomatic patients with heart failure with reduced ejection fraction and heart failure with mildly reduced because it included less than 50% EF, and iron deficiency to alleviate heart failure symptoms and improve quality of life as class 1 indication. And intravenous iron supplementation with ferric carboxyl or ferric derisomaltose should be considered in symptomatic patients with HFrEF and HF mid-range EF and iron deficiency to reduce the risk of heart failure hospitalization. Coming back to our patient, we gave him IV ferric carboxyl dose according to the weight and hemoglobin level. He needed 1,500 milligrams. So the first dose was 1,000 milligrams, and in 6 weeks he repeated 500 milligrams. And actually, 12 weeks later, there was no hospitalization, and his TSAT was 21%, ferritin 107, and hemoglobin level of 13, and he was asymptomatic. And recently, that was published in August 26th with the ESC conference, the HeartFit trial, which the primary outcome was a win ratio, unmatched win ratio of death and hospitalization for heart failure and change from baseline to 6-minute walk test. But actually, it didn't meet statistical significance. But what we learned from this HeartFit trial that we can give IV ferric carboxyl up to a longer duration without any, it is safe without major side effects. And then several meta-analyses have been published showing that the primary endpoint can be met if we take a AFFIRM trial, CONFIRM, and HeartFit trial with IV ferric carboxyl dose, total cardiovascular hospitalization and cardiovascular death, total cardiovascular hospitalization, total heart failure hospitalization, all they are met. So the conclusion was in iron deficient patients with heart failure with reduced EF, intravenous ferric was associated with significantly reduced risk of hospital admission for heart failure and cardiovascular causes with no apparent effect on mortality. But it comes, this is the last part that I will talk about, the definition of iron deficiency. We are relying on ferritin level, but there are some meta-analyses that have been published in 2018 showing that ferritin level is not as effective as other parameters like transferrin saturation. And if we compare to the gold standard, which is bone marrow, this is a study on patients undergoing CABG and with iron deficiency, 42 patients with HFrEF less than 45%. By bone marrow, around 40% of them, they were iron deficient. But the sensitivity and specificity of the guidelines that include the ferritin, it was 82 and 72% if we use the guidelines. But if we use only TSAT saturation, the sensitivity was 94%, sensitivity 84%. And if we use iron level less than 13, 94 and 88%. And only if we use the TSAT saturation less than 20%, it has an impact on all-cause mortality, iron deficiency. And if we use Iron less than 13 micromole per liter, also it has significant impact on mortality. And recently, there was a study that was published in the European Journal of Heart Failure 2023 about the prognostic value of 3 iron deficiency definitions. TSAT less than 20%, serum iron less than 13, and the guideline, which is ferritin less than 100, or TSAT between less than 20 with the ferritin between 100 and 300. And actually, iron less than 13 and TSAT less than 20 has significant impact on the outcome on these patients. So, leaving these two studies at the end, I think I will end by what can I interpret the literature about iron deficiency in heart failure. First of all, definitely iron deficiency is a prognostic factor in heart failure patients. Second, iron deficiency is prevalent even without anemia in heart failure patients. Third, iron deficiency studies available in patients with EF less than 50%. Pending studies, trials in HFpEF patients. Definition of iron deficiency in heart failure is not yet definite. Ferritin versus iron level versus TSAT level. We have to addict to the guideline recommendation, which is ferritin and TSAT. More data suggesting that TSAT level and iron levels are more diagnostic, prognostic, and related to therapy efficacy. In non-anemic heart failure patients, I think I will rely on TSAT and ferritin level. But in anemic patients, ferritin or TSAT or iron can be used. If we have 2 or more of them, then we confirm for sure that the patient has iron deficiency. Treating iron deficiency definitely improves quality of life. And iron deficiency from the HeartFit trial, which was recently published, can be used for long-term use, and it is safe. May reduce heart failure and cardiovascular hospitalization, but no effect on mortality with giving IV iron up till now. And IV ferric carboxyl maltose of IV ferric derazoma maltose can be used in both in iron deficiency anemia. And both studies, the Ironman and AFFIRM-HF, as well as other trials, have shown their efficacy. So the most important message is we should replenish iron at the right time in these patients to reduce hospitalization, as well, the most important, to improve quality of life of these patients. Thank you.
Thanks very much, Dr. Hadi. Great talk, a lot to digest. If I may ask, I think a lot of questions that I was going to ask you already answered at your last slides. Did you use, because the definition of iron deficiency is still not that clear, and you mentioned the importance of the TSATs, particularly maybe people with chronic disease, because ferritin is inflammatory reacting, whatever. What is your cutoff hemoglobin? At what stage you say, I need to check for iron deficiency? Is it 13, 14, 15, or is it male, female, or when you practice, what do you use?
Actually, we should screen for iron deficiency regardless of hemoglobin, but a hemoglobin above 15, even in the ConfirmHF and the FerHF and the AFFIRM-HF, there is no indication to, even if they satisfy the definition of IV iron, there is no studies saying that giving them above 15 is safe and it is efficacious. So upper limit is 15 if we go by the AFFIRM and the ConfirmHF, but if we go by the Ironman trial, it is 13 to 15 in men and 12 to 13 in women. And actually, in the 2023 guidelines, if we read the part on iron, they mention about the cutoff points of hemoglobin as mentioned in the Ironman trial.
Yes.
And you always like to ask about the ferritin and as an inflammatory marker.
Yes.
And this is why this study with these 42 patients with bone marrow pre-cabbage have suggested that, and this is important too, with the recent study that was published about the 3 definitions of iron deficiency, has proven that a ferritin level alone is not sufficient to diagnose iron deficiency in these patients, because it can be because in one of the sub-analysis, a ferritin level less than 100 with a T-SAT above 20%, giving them IV iron did not improve the outcome. So this is why maybe T-SAT level, which is ferritin, which is iron over total iron binding capacity, and an iron level of less than 13 are more important in this analysis. So actually, in my practice nowadays, I'm looking at the iron level and the T-SAT level before giving IV iron. So if I have a patient with a ferritin, let's say 90 or 80, with a T-SAT of 21% and an iron level of 13.5, I'm not giving them or introducing IV iron in these patients because in some meta-analysis they didn't show any efficacy. And they may not be really true iron deficient.
And the issue of symptoms and no symptoms. So even if your patients are iron deficient, but he's quote unquote NIHA 1, you will not prescribe it. Even is that correct? Is that what you do?
The question of symptomatic heart failure, if rarely to find a patient with heart failure who is not really symptomatic. If they are really in NIHA class 1 and they have no symptoms, we can go without prescribing IV iron on these patients. But at the same time, I will tell you, these patients, they may develop symptoms with time. And second thing, deficiency of IV of iron in the myocytes will reduce contractility. So for me, I tend, if we go by the guidelines, no need to prescribe, but a safe drug that may improve contractility in these patients and improve respiratory muscle and skeletal muscle contractility. Why not to prescribe it early on to prevent progression of heart failure? I tend to give these patients, especially if they are really iron deficient.
I don't want to drag this long, but what's your view on actually long-term use of IV iron? We're knowing from the heart-fed trial that actually the benefit actually was within the first year, and the second year actually the benefit almost lost. And when I was hearing and just the discussion, the European Society among those people who talks about it, and they were saying because we should not now, if the patient we diagnose patient with iron deficiency now, even if this DSAS goes more than 2024, we should keep them. Some do this every 6 months or every year, at least 500 of regardless of their TSAT, unless it goes like more than 40%, whatever. I mean, something I don't do, but I mean, do you prescribe to this? Does that make sense? It's not guidelines.
No, we have to stick with, if they are persistently iron deficient, we have to replenish them every 6 months. Maybe we have to screen them later on the long term. But the heart-fed trial, actually, they included patients with a less sick than the other patients, especially the Fermi-HF trial and the Ironman trial, where they included patients recently hospitalized or hospitalized. And this is one thing maybe why the study was negative, but also the definition was based on either ferritin less than 100 or TSAT less than 20%. So we have some patients that may be non-iron deficient in these patients. So maybe in the future, having trials just relying on transferritin saturation and ferritin and iron levels may have a different impact, because as I told you before, giving IV iron in patients with TSAT less than 20% and even less than 12%, they have more efficacy than just giving them on a patient with a TSAT at more than 20%.
Can I mention just one thing before I close on this? The hypophosphatemia, did you check for it? And I don't. Do you check for it? I always get that you have to check it. It's good, kind of low phosphate. Is that something you do? What's your views on hypophosphatemia with carb?
This has been gained some it was the hot topic last year about hypophosphatemia and the patients receiving IV iron, but actually from studies in heart failure patients, there was a meta-analysis too that the risk of hypophosphatemia is really is very low. Hypophosphatemia occurs mainly in normal patients, like with a frequent intake of frequent IV iron, like in normal female patients, young patients. It may occur, but in CKD patient or iron or heart failure patient, it's rarely, because most heart failure, 50% of our heart failure patients, they have some element of a low eGFR, and this will not cause the patient to develop hypophosphatemia. So I usually in my practice don't look for phosphate level in these patients, because even if we develop hypophosphatemia, severe hypophosphatemia to cause symptoms is rarely to develop. So a phosphate level less than 1. So even if it's mild or moderate, what is the clinical impact of that? Nobody knows.
Great, thank you. Well, that's very great. Thank you very much. I will summarize actually probably Dr. Hashmet in your talk in a few minutes before I give my own talk. So we learned from Dr. Hashmet that again, hyperkalemia is very, very common in what they call chronic heart failure, up to 50%, in acute heart failure, up to 85%. Hyperkalemia, we have to have a low threshold to defining it. 5 millimole is hyperkalemia. Even if no potassium normalized, because you reduce it, your ASOR, then you should try to reintroduce it. It's really harmful just to deny patient effective therapy, RAS inhibitors, because you actually increase your morbidity and mortality. Have a low threshold to use this available, safe, slightly expensive potassium-chelating agents. We learned from Dr. Skoury, iron deficiency is very common in heart failure. I think I might confuse with hyperkalemia. The 85% in acute heart failure, 55% in stable heart failure. You can have iron deficiency without having anemia. You have to. It's class 1 recommendation to screen your patient for iron deficiency, not for anemia, as long as their hemoglobin 15 or less. And oral therapy, somebody asked a question in the chat box, oral therapy or IM therapy doesn't work, erythropoietin does not work, it's IV iron, whether it is carboxymaltose, dexamethasone, or sucrose, which is sucrose is very small dose, it's not really practical. So it's IV iron, and you should use the standard definitions of the stats less than 24%, or ferritin less than 100, or if the ferritin between 100 and 300, the T-sats less than 24. The dose is variable, but usually 1,000, and then followed by 500, then you follow up your patient. It's very effective. It's a class 1 recommendation to reduce symptoms, a class 2A recommendation to reduce hospitalization. I'm very grateful for my two colleagues, and I will now move on to my talk. I'm just going to share my screen. So just go up. So my talk was going to be on the legacy of SGLT2 inhibitors in heart failure across all ejection fractions. So I'll just talk you through SGLT2 inhibitors in heart failure from when it started till now. A lot of it, I'm sure you know, but there'll be hopefully some refreshment, and feel free to ask and interrupt. It might take part of it. So what I would very quickly mention the burden of heart failure and the evolvement of the medical management of HFrEF, then a role of SGLT2 inhibitors in HFrEF, and with basic DABA heart failure and the EMBA-REDUCE. Then I'll talk about the guidelines that came after that, 2021, 2022 in HFrEF, and then move on to the heart failure, evolvement of medical management of the heart failure with mild reduced ejection fraction and heart failure with preserved ejection fraction, and the role of SGLT2 inhibitors in these situations with the EMBA-PRESERVE and the DELIVER trial. And then I will talk about the pooled analysis of a lot of the SGLT2 inhibitor studies, that should give you some insight of what is the, what did they mean and what's the best, how the effective in which patient you use it for. And then We'll finish with the focus update. It was just presented and published a few weeks ago in European Cardiology in the heart failure. So heart failure is very common, up to 5% in some parts of the world. They estimate about nearly 65,000 million patients are now living with heart failure. More than half of it are heart failure with court-preserved ejection fraction. It is still continue to have high mortality. We've been fortunate as far as the HFrEF. There were so many trials that gave us a lot of effective therapy that reduced morbidity and mortality. We should not forget the ACE inhibitors and the ARB that reduce mortality by 18%. Beta blocker, major thing. You never stop beta blocker. You should give beta blocker to everyone with HFrEF because it actually gives you 35% reduction in all-cause mortality, death. So don't forget those. And the MRAs, again extra 30% reduction in mortality by using spinal to neuropileurinol. Then we had a long gap until 2015 when we had this landmark trial of the paradigm, gave us a fantastic drug, the security of valsartan, which when tested against an active comparator, enalapril, which we know it works, it reduced mortality by 18%, but they challenged it with the security of valsartan and showed that it's better in this patient with HFrEF that actually reduced all outcome, mortality, morbidity, sudden death, quality of life, renal function, everything better when you're given this drug. So it's a fantastic drug. It's clearly then the guidelines that came after these trials in 2016, 2017 incorporated security of valsartan plus the ACE inhibitors and MRAs and beta blockers in their guidelines, although they, as you remember before, it's give them in a stepwise fashion. So give one at the other, wait and titrate dose. Something takes forever, which now no longer recommended. But in spite of all these trials, we continue to have high morbidity and mortality. And even if you look at the latest at that time, the paradigm trial. So when you look at the active arm, the people actually were on the good drug, the security of valsartan, we did much better than the enalapril. Still in that group, in that good group, up to 22% either die or have heart failure hospitalization within 2 years. So we still really have a lot to do to improve the medical management of heart failure, which we have been doing very well. So after that, what happened? We have these new drugs. They came out of nowhere. Nobody even thought that diabetic medication can be used for heart failure. But talking about SGLT2 inhibitors, you probably know they are diabetic medication. They reduce the reabsorption of glucose in proximity to cause glucosuria, improve your glucose. Okay, great. But thanks to the FDA, which has really put really quite strong regulations, that now any drug that you want to test for diabetes, you have to show us that it is safe in diabetic with higher risk of cardiovascular disease. So all the drugs had to be tested. The drug company had no choice. And they tested all these SGLT2 inhibitors, the MBA, the CANA, the DABA, and they found not only they are safe, but actually they reduce MACE, reduce stroke, cardiovascular death, whatever, but also, surprisingly, they reduce heart failure hospitalization. What? They reduce cardiac death, cardiovascular death, they reduce cardiovascular death and heart failure hospitalization. That's what surprised. So the logic was, let's see, do they work in heart failure? If we test them separately on their own. And there come the first and landmark trial in this regard, which is DABA heart failure trial. It's a huge trial. It's nearly 5,000 patients. Look, diabetic and non-diabetic, not only diabetic, anybody with heart failure with reduced ejection fraction, they get enrolled in this study. And the primary outcome is a combination of cardiovascular death or worsening heart failure. Worsening heart failure defined as admission to hospital with acute heart failure or urgent attendance with heart failure. Either you go to a clinic or ER with worsening symptoms, the medication has to be modified or given IV treatment. That will be as an endpoint. They were on fantastic drugs. You cannot ask for better than this. More than 95% RAS blockers, beta blockers. Look, MRA, they were 70% on MRA. We don't even do this current day. So really on a good treatment, basically. And the trial really met its primary and secondary endpoint with 26% reduction. And the primary endpoint of cardiovascular death or worsening heart failure, number to treat is only 21, effect seen within 28 days. So don't defer, don't delay, start now. The effect, you will see it quickly. You defer, you lose patient. Patient get admitted to the hospital because you did not start them on treatment. And there was actually 18% relative risk reduction of cardiac death. Cardiovascular death was reduced by this drug. It's diabetic medication. It actually reduces your cardiovascular death. It reduces your heart failure, worsening heart failure by 30%. I mean, what else do you want? And it showed actually it's effective across all ages. So even if you are 80 years old or you're not 90 years old, you get benefit from being on this drug across all outcomes. So don't say this is, or 70, 80 years old, I will not do, what's the point of giving? And it does, because even stopping them getting into the hospital, that's major achievement. And it also, it's diabetic, I cannot see the top of the thing. So the effect seen across all ejection fraction, even that narrow range, the small range, basically that's what's this like. And it is independent of other drugs. So whether you're on ARNI or beta blocker, you're not, the drug will help you. So don't say our patient cannot take beta blockers and ACE or ARB or ARNI. So what's the point of him at SGLT2 inhibitor? No, there is, because the drug works independent. Ideally, you should be on all the drugs. But if somebody cannot take beta blocker because they are always slow, whatever, or MRA because of bad kidneys, whatever, and you can still give them this drug because it still works independent. So it is add-on independent effect. And it works when you're diabetic or non-diabetic. A lot of patients come to a doctor. The other doctor told me this is a diabetic medication. Why are you giving it to me? Because it's no longer diabetic medication. It's a heart failure medication. So it works for you, my friend, or my patient. Not only heart failure hospitalization or cardiovascular death, but quality of life. It's very important. You need to make your patient feel better. And this is KCCQ score at baseline in 8 months, significant improvement. So patients get feeling better in themselves just by giving medication. And patient feels better, less admission, less death, a drug one. And they found actually in non-diabetic, if they give them this drug, you are less likely to develop this is about the kidney. So less likely, this was not powered to do this, but it showed that actually it's basically less likely to make your kidney worse. And you are less likely to develop diabetes if you're not diabetic on this medication. 32 relative risk reduction of the risk of becoming diabetic if you're on this drug. Okay? Win-win. And then came the EMBA reduce, this to complement. This is very similar design, nearly 4,000 patients. Ejection fraction less than 40%, EMBA versus placebo, diabetic and non-diabetic, follow-up for 6 months, primary composite endpoint of educated cardiovascular death, heart failure hospitalization. Secondary endpoints will come to heart failure hospitalization, kidney effect. Again, the trial meets its primary and secondary endpoints with a significant relative risk reduction, 25% of cardiovascular death, heart failure hospitalization, predominantly driven by reduction in heart failure hospitalization, which is 30%. There was no significant reduction in cardiovascular death with the EMBA in this study compared to the DABA. And there was significant reduction in the worsening or of the kidney function using this drug. So it's kidney protective. We know this from this study, and we know this from subsequent studies. It's really it works, helps your kidney. You should give it. And when you put these two trials together, the EMBA reduced the DABA heart failure together, meta-analysis, we looked at really basically with SGLT2 inhibitor, you get significant reduction of cardiovascular death, heart failure hospitalization. You get significant reduction in pure heart failure hospitalization. You get significant reduction in cardiovascular death, and this driven predominantly by the data from the heart failure. Significant reduction in the worsening of kidney function, driven predominantly by the EMBA reduce. So the guidelines have to move on, have to change. So with the 2021 European, 2022 American guidelines, has brought these guidelines from nowhere. They're becoming class 1 recommendation, and they are step 1. You have to start all the 4 pillars as soon as you can, as it's safe to do so. So, SGLT2 came on straight and as class 1, start early. Wow. Okay, and the American highlight the fact that the DABA is the only one that demonstrates significant reduction in cardiovascular death. A lot of people believe this is a class thing. Anyway, but they are a good drug, fantastic drug, not a good drug. What about heart failure with mild reduced ejection fraction and heart failure with preserved ejection fraction? It's common if you get the proportion of heart failure with preserved ejection fraction actually getting higher compared to with reduced ejection fraction, although the prevalence for all heart failure is going up all the time. Mortality is similar. Unfortunately, over the last 2-3 decades, we did not have effective therapy. We tried so many drugs. We'll go quickly through a few of them, but none was really convincing. The ACE inhibitors in this trial did not make much difference. The R in the CHARM preserve trial, a big study, recruiting patients with heart failure with mildly reduced and preserved ejection fraction, randomized them to cancer versus placebo. Unfortunately, it just missed the statistical significance as primary endpoint cardiovascular death, heart failure hospitalization, but did reduce heart failure hospitalization and therefore become class 2B recommendation. You may consider it. Similar story with the TOPCAT, although you can argue about the details of the study, but basically the MRAs found electronic heart failure with ejection fraction equal to more than 45%, did not meet the primary endpoint of cardiovascular death, heart failure hospitalization, but did reduce heart failure hospitalization and has become and still is class 2B, you may consider it. Then the security phosphatidylate did magic in the HFrEF. So it was tested in the HFpEF in the Paragon trial. Again, a huge study, more than 4,500 patients, heart failure with ejection fraction more than 45%. But they did the same thing. They converted them not to placebo, they converted them to active comparator, which is always a challenge. And they did not include the urgent heart failure visit, they just included heart failure hospitalization. And the study basically for the primary event, although reduced by 13%, did not meet its statistical significance. Therefore, it's seen as did not meet its primary endpoint, although we know it works in women, works in everyone with ejection fraction up to 57%. But it reduced heart failure hospitalization, though, so it's being kept in the guidelines class 2B recommendation for heart failure with mildly reduced ejection fraction. The breakthrough occurred when, again, with the SGLT2 inhibitor that came from nowhere in the HFrEF and then being tested in HFpEF. And now this is the reverse. The MBAC glutathione was tested, the trial of the MBAC came first, which is the MBAC Reserve trial. Again, because, HFpEF patients tend to be, older women with a lot of comorbidity, they tend to die from other lots of non-cardiac cause. So to really evaluate from the cardiac point of view, you need a bigger number and need a longer follow-up. So that's why they have nearly 6,000 patients in the study, and EMBA versus placebo, and they followed them up for nearly 26 months. Again, diabetic and non-diabetic, looking at the primary secondary endpoint similar to the reduced. And the trial was surprisingly very successful, met its primary and secondary endpoint with 21 relative risk reduction of cardiovascular death, heart failure, hospitalization. Number 3, only 31. This is all driven by reduction in heart failure hospitalization. There was no reduction in cardiovascular death. But that was not the primary endpoint. The primary endpoint was this one. It met the primary endpoint. And what they found in this study, that the effect of EMBA it seems to attenuate, becomes less effective at ejection fraction more than 60%. And the question, is this true, or is it or a random subgroup finding or spurious results? Would that become clearer with the other study? Let's start with the DELIVER. The DELIVER was really much bigger. This is the largest trial in HFpEF patients, including recruiting 6,263 patients, anywhere with ejection fraction more than 40%, so mildly reduced or preserved. And they were a bit actually loose and maybe similar in their diagnosis of HFpEF. All what you need is just raised biopsy symptoms, ejection fraction more than 40%, and in your echo you just need either LVH or a large LA. So you don't have to have that sophisticated, complicated score that being recommended. So it's similar to diagnosis needed. And the study, most of the patients actually were class 2. They were not actually all admitted to hospital, just coming and working and to clinic and say, I'm getting breathless when I woke upstairs, stuff like that. And the study included patients also who has been either during hospitalization or been just discharged within 90 days. And those this constitute about 16% of the population. So basically studying in patient during hospitalization as well as ambulatory. And also again, diabetic and non-diabetic. And if you look at the split of the group, 30% had ejection fraction more than 60%. So we wanted to look at this group. Does this drug in this group, does this drug work in this group or not? And 18%, which nearly 18.4%, which actually 1,151 patients were heart failure with improved ejection fraction. These are the people who had HFrEF, but then ejection fraction improved to more than 40%. And a lot of us, particularly become ejection fraction towards normal, we tend to stop medication. And the TREAD heart failure trial told us if you stop, heart failure can relapse, and the guidelines tell us not to stop. But this trial did not look into stopping, looking into initiating this drug in patients who actually heart failure ejection fraction has improved. Do they get better if we add medication like the SGLT2? Really interesting. So DELIVER is the largest number-wise and most inclusive because it includes all this inpatient, outpatient, ejection fraction more than 60%, heart failure with improved ejection fraction. So really very huge study. And the study was really, really successful. It's with the primary, secondary endpoint with 18% relative risk, significant relative risk reduction of cardiovascular death or worsening heart failure. The effect was seen within 13 days. So give your patient treatment early, get the benefit early, do not defer. It works. And there was 20% relative risk reduction in heart failure or worsening heart failure, and non-significant 12% reduction in cardiovascular death. And looking at the patient ejection fraction less than 60% versus the whole population, including the 30% above 60%, they derive the same benefit. So it works in patients with ejection fraction more than 60%. And there's no attenuation. And it works also, patients who actually been given this drug during hospitalization earlier on after discharge, it works for them. And those with the improved ejection fraction, they will derive benefit by adding SGLT2 inhibitors. So it's all group. It is consistency. It is uniform effect in all these subgroups. And it reminds you, the TREAD heart failure told us not to stop, but the DELIVER told us to start a patient with heart failure with improved ejection fraction on SGLT2 inhibitors. And the effect was seen in diabetic and non-diabetic, seen with ejection fraction less than 60% or more than 60%. All subgroups, across all subgroups, consistency, effective, homogeneity. There's no heterogeneity across all ejection fraction, up to 75%. It works. And quality of life improves again. So your quality of life more likely to improve when you're in this drug and less likely to deteriorate when you go in this. So if you put the patient who actually when whom and heart failure patient treated with DABA, that would be DABA heart failure and the DELIVER. So across all ejection fraction, but using just the DABA. And this is 11,000 patients. We're not talking about 50 or 60 patients, 100. 11,000 patients. And if you add DABA to DELIVER, and they benefit across all ejection fraction up to 75%. And across all the across all the NT-proBNP. So don't say this patient had NT-proBNP 6,000, he'll benefit, but that one with 600 will not benefit. They will benefit. Even 400 BNP will benefit. So all people will benefit. People even with lower NT-proBNP will benefit. Diabetic, non-diabetic, kidney, improved or not improved. All ejection fraction 60% less. We all benefit. It's a simple drug, once daily, it's safe. And we know from the RASI trial that the effect, the benefit tend to attenuate towards higher ejection fraction. So the RNA, even digitals, which I use at times, the MRA, the benefit attenuates toward the 55, 50, whatever. The MBA went up to 60%, which is good. But the DABA, there's no attenuation at all as far as ejection fraction is concerned. And if you look at the DABA using heart failure, and DELIVER, if you have all of them, if you give patient DABA, you get first 14% relative risk reduction of cardiovascular death and 10% significant reduction in all-cause death. Get nearly 30% reduction in heart failure hospitalization total, and 26% reduction in the first heart failure hospitalization, and 10% reduction in all MACE, cardiovascular death, MI, or stroke. You prevent even the stroke. I mean, what else you want? And data on the kidneys are endless as well. So, and if we put the meta-analysis of the DELIVER and the EMBRA, so we look at the effect of SGLT2 inhibitors in HFpEF and HFmREF. Okay. So if you look at the study, they look very similar. Look at the graphs. You cannot tell which is one the EMBRA, which one the DELIVER. So the primary input was very similar, very effective. Both are effective. And if you add them all together, basically use SGLT2 inhibitors in heart patient with HFmREF and HFpEF, you get 20% relative risk reduction of the primary endpoint of cardiovascular death, heart failure hospitalization, driven predominantly by reduction in heart failure hospitalization. And And again, SGLT2 inhibitor really improve your quality of life. Most of your HFpEF patients, those obese women, wheelchair, COPD, obstructive apnea, atrial fibrillation, they have poor quality of life, worse than they have refraction. And these drugs improve their quality of life. They make them feel better. Not only reduce hospitalization, reduce cardiovascular death. And if we put all the maintenance of all this here together, we are now expanding. What do you mean by the 5? Now, the 5th one I didn't mention is the sotagliflozin, which was studied in diabetic patients admitted or shortly after discharge with acute decompensated heart failure, regardless of their ejection fraction, although 75% had ejection fraction less than 50%. But these are diabetic patients. It's a big study. And sotagliflozin is an SGLT1, SGLT2 inhibitor. The trial was really, really positive. I mean, what was absolute risk reduction 25%. You need to treat only 4 patients to derive benefit. So if you add this trial, the SILOWEST plus the EMBRA-reduced, EMBRA-preserved, DELIVER, DABA together, so this SGLT2 inhibitors in all heart failure, what you get? You 23 by using SGLT2 inhibitor, you get 23% relative risk reduction of primary inborn heart failure, hospitalization, cardiovascular death. You get 28% relative risk reduction of risk of hospitalization. You get 13% relative risk reduction of cardiovascular death. You get 8% reduction of all-cause death. So all-cause death improved by giving the SGLT2. You should give it. Don't even think twice. And this is now meta-analysis, all SGLT2 inhibitor trial, not only heart failure, but first was tested in diabetic patients with high risks to the left group, and then tested in heart failure, which we talked about, the 5 trials, and then also tested in chronic kidney disease. Do you know how many patients we add SGLT2 inhibitor in all these patients? 90,413 patients. And if you look at all this trial from the reduction, if you give these patients, whether they are diabetic high risk, obviously the heart failure or the chronic kidney disease, they give them SGLT2 inhibitors, do you reduce cardiovascular death, heart failure, hospitalization? We're just going to look at it from this side only. Yes, it does. If you're diabetic, you certainly get benefit. If you're diabetic cardiovascular and have a high risk cardiovascular disease, you reduce heart failure, cardiovascular death. If you have stable heart failure, as we shown, you do. If you have chronic kidney disease, you do. But if you are not diabetic, only if you have stable heart failure, you benefit. If you have only chronic kidney disease, you don't benefit. But to be honest, which patient non-diabetic have chronic kidney disease and they don't have other risk factors? But basically, it's a magic drug. It works. So what the guidelines? Let's go to the guidelines. Guidelines 2021 as far as the heart failure. I'm looking about the HFrEF because we mentioned it. This is about the HFpEF and HFmrEF. In the 2021, all what it says, really, you have +1 recommendation. You have to just screen, and which is important for underlying cause and treat, and give them diuretic. That's it. The American guidelines came last year after the EMBRA-preserved, but before they deliver, and put SGLT2 inhibitor as class 2A. You should consider it. Others as class 2B. But in May of this year, the American College of Cardiology came up with this paper called Consensus Decision Pathway on the Management of Heart Failure with Preserved Ejection Fraction, and basically tell us that SGLT2 inhibitor should be the first line. It's yellow means class 2A, but they are surrounded by green. That's going to be a class 1, as we know from the European, probably next American. And the others are class 2B, as you may consider them. The FOCS guidelines that just came up a few weeks ago. Basically, there was an argument, I just need to mention this briefly. They wanted to actually get rid of the heart failure with mildly reduced ejection fraction. The group with the ejection fraction 41 to 49. And what they want to have 2 classes. One called HFrEF, ejection fraction equal to less than 40%, and the other called them HFnEF. Sorry, apologies. One group called HFrEF, ejection fraction up to 49%. This is the HFrEF, and the above 50% and above call it HFnEF, or heart failure with normal ejection fraction. And guess what? When they met, this is what we were told, that 71% of the committee voted to get rid of the HFmrEF, but they needed 75%. They didn't get it, so that's why they kept this nomenclature. Anyway, so basically, based on the DELIVER and the EMBRA-preserved, Now, in the heart failure with mildly reduced ejection fraction, the GABA class 1 recommendation, diuretics for congestion, and the other drugs are class 2B. Okay? And this is the SGLT2 inhibitors to reduce your risk of hospitalization or cardiovascular death. For the HFpEF itself, obviously, diuretic for congestion, DABA, and IMBA class 1, and then treat and look for a cause. And this is also to reduce heart failure, hospitalization, or cardiovascular death. And obviously, DABA or IMBA. Okay? And for the diabetic with kidney disease, we've been told before in the 2021 that SGLT2 inhibitors are recommended in patients with type 2 diabetes who are at high risk of to reduce hospitalization with heart failure. It's class 1 recommendation. And the 2023 basically said people with diabetes and CKD, again, you have to give them DABA or IMBA. And that's it. I'm done. So if anyone have a question, or I'll look to my messages. Can we give SGLT2 in cancer patients, cancer-related cardiovascular toxicity? Yes, of course. So any heart failure, you give them SGLT2 inhibitors. I told you, it's with HFrEF, it's very, it's very safe drug. There's no contraindication really, unless you have eGFR less than 20, type 1 type diabetes, you don't give it, pregnancy, you don't give it, otherwise you give it. It doesn't cause anything. It actually improves the hyperkalemia. Genital infection is not an issue really, because hygiene, you have to look after themselves. There are hardly any contraindications. It doesn't lower your blood pressure. If the patient with diabetes and heart failure, heart risk in terms of dose. The dose of the SGLT2 inhibitor is 10 milligram. It's 10 milligram with DABA or IMBA. The IMBA 25 milligram is not for heart failure. 10 milligram the dose. I think that's it. I think that Hussein wrote, how do we handle UTI in elderly ladies when they are? Yeah, this is always difficult. I think the rule I've been told and I'm following that if you have a 3 UTI, what is your you may have to stop it. But the advice really is just to, again, hygiene, antibiotic checking, whatever. But I don't stop it after 1 UTI. So, I see a lot of urologists and nephrologists stop it. Somebody write this on the slides. We can write to Khalid or message Khalid and we'll look into it. Any other questions? Another, probably. Khalid, shall I close up? Can we pass the time? Okay, please. I think there will be an evaluation form, so you need to fill it to get your CME points. I was told to remind you. I'm very, very grateful and really to my dear friends, Dr. Hussein and Dr. Hishmet, for really accepting the invite and give us really very interesting talks. You always learn whatever you think you always learn from listening to people discussing things, and I appreciate that they're really giving us the time, and hopefully we'll meet in other occasions. Do you want to say anything, Dr. Hadi or Dr. Hishmet?
I would like to thank you, Dr. Harari, for inviting us and having this wonderful session. We've covered many aspects of heart failure, and I see a lot of enthusiasm and interaction from the audience. So thank you so much.
Thank you.
Also, Muhammad, I really want to thank you for the invitation too. It was a wonderful session, and the topics are well chosen, and actually they are in the 2023 updates of the heart failure. So, and hopefully I can participate, and Dr. Hishmet for sure participate in the next sessions.
Very much appreciated. Okay, I think with that, we'll probably close off. Thank you. Unless Khalid wants to say anything, or Hazem, I'll just close up.